This program is brought to you by Emory University.
Good morning, everybody. Welcome to Friday Morning Conference. It's my pleasure this morning to introduce our speaker, Dr. Terry McLaughlin. For those of you that have not met Terry, he is a first-year fellow in our clinical track, native of Buffalo, New York. He did his undergraduate in medical school at the University of Buffalo, left the friendly confines of Buffalo for residency, where he trained at University of Pittsburgh. And his wife is a pediatric cardiology fellow across the street at Children's. So he's going to talk to us today about imaging, looks like inpatient cardiac imaging. So Terry, all yours.
Thank you, Dr. Williams. Thanks everyone for the opportunity this morning. As Dr. Williams just said, I just finished up a month on the Hurst service with the guidance of Dr. Sperling and Dr. Kayumi. And we had a number of times where we thought about doing various nuclear imaging for patients. And I just kind of wanted to review why we do the things we do and kind of maybe what we could do a little bit differently and kind of how we got to where we are. First off, I have no disclosures. So the three topics I'd like to discuss today are the use of beta blockers during the time of a pharmacologic myocardial perfusion imaging, whether or not they should be discontinued before the procedure, myocardial viability in the setting of revascularization with coronary bypasses, and kind of trying to figure out how we got to where we are today in terms of our practice patterns and whether it improves outcomes. And I'd like to finish up talking about essentially PYP scans for ATTR amyloid, kind of how we interpret the study, how we got to where we were interpreting the study, kind of the characteristics of the study. So I'll start with a case, not uncommon for the Hurst service, general medicine service, any service really. 72-year-old man with a history of coronary disease, had a remote stent. He's on a beta blocker, comes in with chest pain. EKG is not overtly ischemic. Troponin levels trended normal, but given his high pretest probability, we plan for a PET stress test in the morning. Question becomes, should we hold the beta blocker? Thinking about how beta blockers work, they are essentially an anti-stress test. They're going to reduce the myocardial contraction, reduce the heart rate, reduce the blood pressure, and overall reduce myocardial demand. And then when we think about our vasodilator myocardial perfusion imaging images, the way we obtain these the effects of the perfusion imaging are through largely, and when we do it with the regadenosine, most commonly our A2 receptors. I highlight this because when we think of the method of action of beta blockers, we need to take into account that the beta blockers share some pathways with this adenosine 2A receptor and may interact. The beta 2 receptors may interact, and it may interfere with the adenosine vasodilation. Furthermore, they help prevent, the non-selective beta blockers help prevent paradoxical vasoconstriction and abnormal coronary arteries. And that usually results in a favorable vasomotor tone and adds the benefit of preventing coronary steal and improves endocardial perfusion, which is what we're trying to assess with these stress tests. And finally, the selective beta blockers don't have the vasodilatory properties, and they may cause vasoconstriction and decrease blood flow to normal coronary arteries. So they may interact in a number of ways. Despite what we know about the pharmacology of beta blockers, but we've been doing stress tests for many decades now. The data currently helping us determine whether or not we should continue or stop them is somewhat conflicting. There's no large-scale trials evaluating this question, and really there's no consensus that exists. And I think this is best evidenced by the American Society of Nuclear Cardiology's 2016 guidelines, which state that something that we know can somewhat ascertain from the data I'll show shortly, that there are anti-ischemic effects of cardiac medications like beta blockers, and they may decrease the accuracy of vasodilator stress tests. And discontinuation of the beta blocker is left to the discretion of the referring physician. So this paper from JACC in 2008 is a review kind of all the data we have regarding this topic. And I think it does a good job of putting together that information up until that point. The interesting thing is, if you look through their table 1, they kind of identify how many patients and what type of, whether it's exercise or myocardial perfusion stress testing they do, what treatment they would do, randomizing to which specific beta blocker versus placebo, and then what the difference is in the various evaluations of perfusion. So this first one from 1989 out of the American Heart Journal took 12 patients. It's actually with exercise thallium SPECT, so a little bit outside of the scope of what we're discussing today with the pharmacologic, but it assessed essentially propranolol versus placebo. And they did it for a couple weeks. And what they found was the defect size in the placebo was significantly larger than that of the same person using the beta blocker and repeating the test. Next, in 1992 from Nuclear Medicine Communication, they retested this question again with 12 patients with dipyridamole, SPECT, with thallium. They did atenolol for a week versus placebo for a week. And now they found no difference when comparing to the baseline. In 97, in the American Journal of Cardiology, they repeated this sort of question again with 17 patients with a dobutamine, technetium, SPECT. They used intravenous propranolol versus not propranolol. And what they found is in their stress sum score and the stress difference score, there was a significant difference between the use of propranolol. There's, I think, 3 more studies in this review, from this one in 97 as well from Journal of Nuclear Cardiology, this time using 10 patients, dipyridamole with an ammonia PET, metoprolol orally 12 hours before and 1 hour before the study. And they looked at the coronary flow reserve, and they did find that the flow reserve was significantly different between the use of the beta blocker and not. Then we get to an article in 2003 in JACC. I'm going to skip over this one because I'm going to discuss it a little bit more in depth next. Again, in 2003, Journal of Nuclear Cardiology, 14 patients with known coronary disease, dipyridamole, ammonia SPECT, or PET, beta blocker versus holding the beta blocker for 5 half-lives. They found no significant difference between the use of beta blocker and continuing the beta blocker. And then in Journal of Nuclear Cardiology in 2004, 36 patients this time with CAD, adenosine, PET, ammonia stress, 12 weeks of beta blocker versus holding it for the week before, and they didn't find any difference. So kind of in sum from this review article in 2008, we had not that many patients, 122, in 7 different trials. 4 seemed to show a difference and 3 were without a difference. So I was kind of wondering since then how much literature there is, and there's not that much. And what I can find comes from another article in the Journal of Nuclear Cardiology in 2014, assessing this question again, 20 patients, not that many, with an adenosine ammonia PET. It was whether or not withdrawal for half-lives creates a difference. And they did find there was a significant difference between the myocardial blood flow globally. However, when they looked into it more differently, it only differed the interpretation in 2 cases out of the 20 patients. And then finally, one of the other more recent articles I could find is out of an Iranian journal, Daru, that looked at 120 patients with coronary disease on beta blockers for 3 months, and then did a dipyridamole SPECT, essentially tested with versus without, and they could not find a difference between the 2. So I started off with this question, specifically because on rounds, a lot of times when I'd be rounding with Dr. Kayumi or Dr. Sperling, I would say I was holding the beta blocker before the stress test in the morning, and they would say why, and I would say the PET lab would normally tell us we have to. So I wanted to answer this question, but after digging through this data, it seems like the data is conflicted and there's really no good consensus. So I reached out to Dr. Patterson, our nationally recognized nuclear imager, and he referred me back to this article that I referenced above from JACC in 2003 regarding acute beta blocker and the extent and severity of myocardial perfusion defects on dipyramidal technetium SPECT. And not surprisingly, when you look at the rate pressure product, when you used a placebo versus low dose metoprolol, which was intravenous 10 milligrams versus high dose metoprolol, which was intravenous 20 milligrams, your product was not as high. And when you did the stress tests, when you looked at the sum stress scores and the sum difference scores, they actually went down with the use of acute intravenous metoprolol to a significant extent. Here is another chart showing the difference between the two tests among the 21 patients that were included in the study. And overall, there was a lower ability, or made for smaller defects and less severe defects. Here are a couple examples they use in the study, just to put it pictorially. You can see that at rest versus with the high dose versus the low dose, you start to, with the placebo, you'll pick up these sort of images, these sort of findings in perfusion where you may not pick it up in the low or high dose metoprolol sort of repeat studies. Same sort of findings occur over here where there was an anteroseptal defect that could have been missed by using the IV metoprolol before the procedures. The problem with all of this data, I think, is, or with this study specifically, is, again, like all the other studies, it's only 21 patients and they already have known coronary disease. So you could really only discuss sensitivity rather than specificity in this case. And when you look at the sensitivity of the test, it was 69% when you use the placebo versus 52% when you're using the metoprolol, which still I don't think is as high as we would anticipate for our typical myocardial perfusion imaging. Additionally, in this study, which may be regarded as one of the more important studies on the topic, it's acute intravenous metoprolol versus chronic oral metoprolol, which we're usually dealing with when we do these studies. It's a beta-1 selective, so I don't know that it's applicable to all beta blockers. This is a SPECT study rather than a PET study, which was our question. I think they're relatively similar. And then whether or not using dipyramidol versus adenosine makes a difference. So taking it in sum, kind of what I have found from the data is it's still a matter of debate. The guidelines defer to the provider, and in my experience, at least, talking to experienced cardiologists, depends on who you ask whether or not they would like to continue or discontinue the beta blocker. What I always try to keep in mind as well is what the indication for the test is. If it's diagnosing coronary disease for the first time and you want you don't want any smaller estimations of severity and or defect size, in those that don't have coronary disease, that's more important. Whereas when you have a patient with chronic coronary disease and you're treating them with anti-ischemics, you kind of want to see how the anti-ischemics are working. So the indication for the test, I think, is important. And also, you have to keep in mind that acute beta blocker withdrawal could be deleterious to the individuals in whom you are holding the beta blockers. I suppose I'd wait to the end, but I wouldn't mind hearing from some folks, their practice patterns and their thoughts based on all this data. So moving forward to a second case, to move the imaging discussion forward, to highlight the value of viability studies in those that will be revascularized, specifically with coronary bypasses. We had a 79-year-old man, a history of hypertension, hyperlipidemia, diabetes, coronary disease with remote PCIs, and heart failure with a reduced ejection fraction that was progressively worsening. He was noted to have a reduced EF down to 20 to 25%. He was actually referred in from South Georgia somewhere, saw the interventional group. They got a cath that showed multivessel disease. He was shipped over to the surgeons who did a bypass, and then he was sent back to follow up with his cardiologist down in Georgia, or down in Southern Georgia, I should say. And by the time I admitted him, he had been admitted 3 more times over the subsequent months for decompensated heart failure. The third of which we did a repeat cath to see whether or not his grafts were patent, to make sure they weren't down, causing any of these admissions. So the question I asked myself was, and the team, I should say, was wondering, would this patient have benefited from a viability study prior to the bypass, to see if there would have been improvement with his CABG with regard to his heart failure versus just medical therapy? So interestingly, kind of at the turn of the millennia, we had some non-randomized control trials that were evaluating this question, and it was based retrospectively. And at that point in time, it seems that the answer to the question would be, yes, we probably should do viability studies for these folks. So going back in time, here's an article from 2002 in JACC that addressed whether or not viability testing impacts the prognosis of people with that LV dysfunction and coronary disease, which was a meta-analysis. And what we found from there was the viability was associated with survival, so it seemed. Moving forward to 2004, a review out of the European Heart Journal questioned this again, looking back at data, and said, if you have ischemic cardiomyopathy and you have viability, we should probably revascularize you. And then finally, in 2006, from Circulation, there was this was kind of an expert consensus paper based on retrospective cohort information. And what they found was that in folks that have heart failure with reduced ejection fraction and a PET FDG viability, early interventions would improve survival. And that brought us to an era of assessing this question prospectively in a randomized control trial. A trial which a lot of us have probably heard of before, the STICH trial. Well, sorry, I'll get to that next. But first, in 2007, there was this study that came out of Canada, actually, the PAR2 study, which assessed whether or not a PET would cause improvement with viability compared to the not having a viability study. And they assessed 430 patients, and they tried to figure out if you had PET-guided therapy, if you were trying to figure out whether or not to do the bypass based on that viability versus the standard of care. They ended up noting on their Kaplan-Meier curves for their primary outcome of cardiac death, MI, or a cardiac hospital stay, there was no significant difference between the two, with a hazard ratio of 0.78, going from 0.58 to 1.1. That led further on to what I was referencing before, the STICH trial. The STICH trial was twofold, not only assessing whether or not a revascularization of severely reduced EFs improves outcomes, but also the secondary analysis that was also in the same issue of the New England Journal in 2011 by Dr. Bonow and company, evaluating whether or not myocardial perfusion imaging improves outcomes in this cohort. So to borrow from some of his slides, there were 200 or 1,200 patients that were enrolled in STICH, and it was to the discretion of the center enrolling the patient whether or not they wanted to do a viability study. Interestingly, about half, essentially, 618 patients had the viability studies completed. Whether or not it was a dobutamine stress echo or dobutamine echo or a SPECT, it turned out that 600 of the patients were included, and what they found were that 487 of which had viable myocardium, whereas 114 did not have viable myocardium. From this information, if we look at their kind of figure, their central figure in the article, it looked as if there was a significant difference in the management of patients who had viable tissue versus non-viable tissue, with a hazard ratio of 0.64, which was significant. However, this was the unadjusted univariate analysis, and when they corrected for baseline covariates, that was no longer believed to be significantly different whether or not patients were found to have myocardial viability. And when they looked at this more in depth, whether it was patients with myocardial viability, their Kaplan-Meier curves, or without myocardial viability versus with, there seemed to be no difference. And when they did their test for looking for an interaction of this, the effects of viability on coronary bypasses and mortality, it seemed as if there was the p-value was insignificant for interaction. This was the STICH trial, and this was essentially 5-year data follow-up. So again, this was 2011, and then come the guidelines in 2013 from CIRC. And interestingly, despite this data, we still have recommendations for the imaging viability assessment is reasonable before revascularizing heart failure patients with CAD with a 2A level of grade with a level B evidence, which is kind of interesting because as far as I can tell, it's the retrospective data that said there might be an improvement. However, the prospective randomized control trials up to this point didn't show much of a benefit to doing the viability study. And what was interesting about this study, or unique, I should say, is they continued the follow-up for 10 years actually, and the STICHES, the extended trial assessing the viability, came out in 2019. And similar to the graph we saw previously, looking at whether or not someone had viable myocardium or non-viable myocardium or viable myocardium, there did not seem to be a difference. And when they did analyses for the interaction of using viability, it seemed again to be insignificant at 10 years. So there was a secondary question in this paper, which I found to be interesting. When you were thinking of the viability in terms of mortality, as we just saw, it didn't seem to cause any improvement. But what we did see in these patients were those without viable myocardium did not seem to have much of a change, and if any, a reduction in their EF at 10 years. Whereas those, whether they were in the medical therapy group or the CABG plus medical therapy group, we found that when they had viable myocardium, the ejection fraction went up. So that could be cause for excitement. However, when they analyzed this, whether it was patients in the medical group or the CABG plus medical group, regardless of their EF, again, it was insignificant, the hazard ratio, and didn't seem to cause any benefit. Like I said, a lot of people know this data. I'm kind of preaching to the choir here. Dr. Guyton and Dr. Smith were the individuals who wrote the editorial for the New England Journal regarding this topic. So in sum, when I think back whether or not this individual should have had a viability study and if it would have changed outcomes, I think after looking at the data, it would not affect his mortality. And then finally, to go through a third case regarding questions on imaging on the Hurst service. There were a couple times this month where we were dealing with patients where we were concerned for amyloidosis. So in this instance, we had an 89-year-old with a history of hypertension, hyperlipidemia, stroke, HFpEF, AFib, presented with kind of a subacute progressive dyspnea on exertion. Diuretics were increasing as an outpatient. However, he was still holding on to fluid. So we were admitting for IV diuretics and further workup. His EF showed a mildly reduced EF with diastolic dysfunction, thick ventricular walls, and there was a concern for an infiltrative process. We started off with our serologies before doing any imaging, and what we found were the serum-free light chains, the SPEP, the UPEP with immunofixations were all within normal limits. So cardiac amyloidosis was the suspected culprit in this case. So the question here comes as how do we interpret the PYP scan when we do order it? And what are the test characteristics? Also kind of how we got to where we are with these PYP scans. So if we were to use the guidelines from CIRC that came out in 2020 regarding how to diagnose cardiac ATTR amyloid, as you know, we could have the treatment with tafamidis, which is the end goal of this diagnosis. And also keeping in mind the pathophysiology of amyloidosis, you know, the transthyretin tetramers that break down into misfolded oligomers and end up as amyloid fibrils that deposit in the heart and other organs, but heart, what we're more concerned with in this case. So I like their algorithm. It's very sensible. After you do it a couple times, it's pretty cut and dry. And kind of at the point where we are, we had an 80, this first step, whether or not you think the infiltrative process could be from something other than amyloid, they recommend doing a cardiac MRI first. In this patient's case, we bypassed that as the concern for amyloid with a higher pretest probability. But I'll come back to that, this first fork in the road later in the talk. But here's where we were, where we had the negative or essentially normal serologies, where we were going to our technetium pyrophosphate scan. And then I'll talk further about once you have this scan, how you interpret it, and what it leads to, whether you think it's just run-of-the-mill AL cardiac amyloid or AL amyloidosis affecting the heart, or whether you think it's the ATTR cardiac amyloid. So the first out of Italy back in 2005 is kind of a single center study how the test was somewhat developed, and it provided the namesake to the grading scale for how we interpret these tests. They used not necessarily the PYP scan, but a similar cardiac bone tracer scintigraphy test to evaluate for amyloidosis. And one of their central illustrations here kind of shows what you're looking for when you're looking for amyloidosis. And what they showed was in a normal control, you largely just have bone take-up of the tracer, whereas in AL amyloid, you don't necessarily see it affecting the heart. You see it mostly affecting the bone, whereas ATTR amyloid, you start to see cardiac involvement that's more significant than the remainder of the uptake. Sorry, these graphs are a little bit smaller, but one of their central illustrations pointing out, you know, how this PYP, how their bone tracer scintigraphy scan differentiates ATTR versus AL amyloid. You can see here that in the group 1, the folks that have ATTR amyloid, the heart retention is much higher when compared to, it's significantly higher, I should say, compared to those that have AL amyloidosis or controls that did not have amyloidosis, where The whole body retention somewhat mirrors this process, but not as significant as the heart retention. And as such, the ratio of heart to whole body retention in your ATTR amyloid patients is significantly higher than that of those that have AL amyloid or the controls. And it leads to this semi-quantitative classification of grade 0, where there's no myocardial uptake, like we saw in that on the picture on the left. Grade 1, where your myocardial uptake is less than that of the rib uptake in the thorax. Grade 2, where the myocardial uptake is equal to that of rib uptake. And grade 3, where the myocardial uptake is greater than that of rib uptake. So going back to this picture, these ATTR amyloid pictures over here clearly indicate that the uptake in the heart is more than that of the ribs. Another example of this comes from a review focused on molecular imaging out of Pittsburgh. Actually, one of my former mentors, Dr. Soman, just to steal a couple of pictures from his review showing this again. We're giving evidence or pictorial representations of what we're looking for when we do this grading scale. This would be an instance of grade 1 where the rib uptake is more than that of the heart. Whereas grade 3, you have more heart uptake than that of the ribs. And here's another example of it, putting it all together, that comes from the Circulation article, where they are giving examples of a grade 0 where there's no heart uptake, grade 1 where there is heart uptake similar to the ribs or a little bit less than the ribs, grade 2 where it's about the same as the ribs, and grade 3 where it's more than the ribs. But additionally, the other way that you can classify this is comparing, and how we also use it is comparing the uptake in the heart to that of the contralateral lung. And as you can see here, there's significantly more uptake in the heart than there is on the contralateral lung. And if we go back to the circulation flow chart, you can see that it's either having grade 2 or 3 uptake on your bone tracer scintigraphy scans or technetium pyrophosphate scans, or having a ratio of heart to contralateral lung greater than 1.5. Then how we determined that this is a good test that got it involved or had put such high emphasis on it in the circulation guidelines comes from this validation study in 2016, which was a multi-center study evaluating the test characteristics of this pyrophosphate scan. I always knew it was pretty good, but after reading this article, it provides evidence that the test characteristics are very good for the PYP scan in diagnosing ATTR amyloid. The way that they went about determining these evidence came from taking patients that had suspected cardiac amyloid, whether it was on an echo or an MRI, doing a biopsy and knowing they had cardiac amyloid, or doing eventually working their way to the biopsy to figure out if they have cardiac amyloid or not. And it came down, it's 1,500 patients or so a sizable cohort for the validation. And what they showed was, with regard to the sensitivity and specificity compared to an endomyocardial biopsy, which was the former gold standard for figuring out whether or not someone had ATTR amyloid. If you thought of it as a positive scan, grade 1, 2, or 3 versus a negative scan with grade 0 uptake, in patients with cardiac amyloid deposits, the sensitivity was 88%. And for those that did not have cardiac amyloid, the specificity was 87%. When you evaluated it even further, breaking it down, not just cardiac amyloid, but ATTR amyloid, what you found was for those that had a positive scan with a history of amyloid, the sensitivity was 99%, whereas for those that did not have ATTR amyloid and had a negative scan, the specificity was 68%. When you go further, and rather than just including grade 1, 2, and 3 studies, you just include grade 2 and 3 studies, those with cardiac amyloid had a 97% or 91% specificity compared to those that had grade 0 or grade 1, whereas those that did not have ATTR amyloid, grade 2 to 3 versus grade 0 to 1, had an 87% specificity. So it's when you break it down even further to the higher level grades to diagnose ATTR amyloid, the sensitivity and specificity is very good, 91 and 87% respectively. Whereas if you repeat these evaluations again using a grade 2 or 3 scan versus a grade 1 or 0 scan, and you include the serologies, which we saw as one of the more initial steps in evaluating the individual for amyloidosis, looking to make sure the serum-free light chains ratio is normal, make sure there's no monoclonal clonal proliferation. When you put that together, you figure out that those with ATTR amyloid have a good sensitivity and a good negative predictive, or there's a reasonable negative predictive value of 59%, whereas those who do not have cardiac amyloid and do not have a grade 2 to 3 and no clonal, they have 100% positive predictive value and 100% specificity to sort of ensure with your evaluation diagnostic flow diagram that they do not have amyloidosis. So this kind of provides the evidence over time of how we got to where we are with the CIRC guidelines. And going back, as I said earlier, one of the first steps is determining whether or not someone has amyloidosis versus some other infiltrative process. If the concern is high, you could do a cardiac MRI first. Here is a systematic review and meta-analysis from 2019 out of the European Heart Failure Journal, kind of looking at the difference between the bone tracer scintigraphy imaging and cardiac MRI. And they looked through about 3,000 different articles, and they ended up including, after excluding for various reasons, 27 articles in their analysis. So the question becomes, but wait, cardiac MRI is the first step in guidelines. Why am I talking so much about the PYP scan? Well, in their meta-analysis, what they found was when you compare scintigraphy, like bone tracer scintigraphy versus a myocardial biopsy in diagnosing amyloidosis of any kind involving the heart, it's pretty good. And when you take cardiac MRIs and compare it to any biopsy proving amyloidosis, it's also pretty good that the cardiac MRI is also good at diagnosing amyloidosis within the heart. The issue with the cardiac MRIs and why there's importance, it's the PYP scans are thought of as being important, is the cardiac MRI doesn't differentiate between the type of amyloidosis, whether it's AL amyloidosis or ATTR amyloidosis. So when you look at bone tracer scintigraphy versus biopsy proven amyloidosis, you can, based on this meta-analysis, you can with a statistic significant finding prove that based on the study that ATTR can be diagnosed, Whereas when you compare cardiac MRI to biopsy-proven ATTR amyloidosis, you can't really differentiate. It's insignificant in differentiating the two. So to answer the third question, what is the sensitivity, specificity of the PYP scan, and how do you evaluate the findings of said scan? It's pretty sensitive and specific, even more so when you include the serologies. And how do we interpret these studies? Use the scoring classification out of Italy, whether it's a grade 2 to 3, equal to or greater than that of the rib uptake, or greater than 1.5 as a ratio of the heart to contralateral lung. And with that, I'd like to kind of finish and hear anyone's thoughts, specifically on the beta blockers. I found that to be one of the more interesting topics of the three I discussed today. But I wanted to thank Dr. Sperling and Dr. Cumey for a good month on the Hurst service, Dr. Williams for helping me think through the topic to discuss today, Dr. Patterson, who took the time to kind of make sure I was looking at the correct literature for the beta blockers, and of course, my daughter Violet, who was helping me out with putting this talk together.
I love it. Put her to work already. Question from Dr. Sperling that he typed in that I'll read out. Terry, nice job reviewing the data. Agree. Important for us to always ask, what is our clinical question? Given the data from Courage-Berry 2D ischemia, the question should not be, does this patient have significant ischemia when they don't take their beta blocker? Our protocols for exercise testing similarly involve holding the beta blocker. I guess, given the data from Courage-Berry and 2D, the question should not be, does this patient have significant ischemia when they don't take their beta blocker? I guess it should be, do they have it when they take their beta blocker, given the efficacy of medical therapy? I guess I'm reading between the lines there, but your thoughts on that?
Yeah, I totally agree. And I think it goes back to, and I don't know that I stated it that well early on, but trying to figure out, is this a patient you initially want to diagnose coronary disease in, or is this someone you're treating for coronary, presumably stable ischemic heart disease, and whether or not you want to figure out what you're doing for the treatment is being effective? So I think based on the data, it's probably important in those that we know have coronary disease to continue their beta blocker and assess kind of a practical, real life determination of whether they're experiencing ischemia, rather than kind of an artificial, evaluation when they're not on their beta blocker, which is not at the day in, day out, not the treatment we're giving for them. So I think for me, it's reasonable to hold the beta blockers if we don't know they have coronary disease, but if we know they have coronary disease, we probably should continue the beta blockers. With that said, I didn't evaluate fully the literature for exercise stress testing. And one can make the argument that maybe you won't reach, if you do an exercise test, you may be on a beta blocker, you may not reach the goal on the Bruce protocol. However, if you come close enough, can you evaluate the test such that you're answering the question of whether or not the beta blocker is working? Again, I think it harkens back to the question you're asking, whether or not we're treating the patient effectively or whether you're diagnosing coronary disease.
And you sort of hit the nail on the head a little bit there with the holding the beta blocker for the pharmacologic nukes. A lot of it is for more practical reasons as opposed to data-driven reasons. Because a lot of times these folks will get converted. Let's say they come down and they are wheezing, for example, and we have to convert them to a different type of stress test. These other, whether it's an exercise test or even a dobutamine stress echo, those, it is pretty clear that holding the beta blocker improves the mainly just the ability to have the test done to completion, to reach target heart rate. So a lot of times that's the reason why they will have you hold the beta blocker for a pharmacologic stress test is in the off chance they have to be converted to a different type of stress. So it's more practical than data driven. So
Gotcha.
Terry, this is Rob Wilson. Those are great talks and great cases. I, for years, supervised the stress test here on this campus. And the beta blocker question has come up, all the time over the years. I checked, Dr. Goyle is not on this call. I actually just sent him a quick text message because he's as you know, he's very data driven. And I basically texted him, I asked him what is our current protocol here with PET and SPECT, and then what was the data that he referenced? And I just can't remember, because he always, as you know, has great insight. And but that's pretty much, I know, even though I don't supervise here a lot anymore, that's pretty much still the protocols on this campus.
Certainly.
And it's been a question, it's always an issue, and particularly for me with our AFib patients, when they hold their beta blocker for 2 days and they come in and they're already at 140, and you want to put them on the treadmill. But there's some conflicting data, as you've shown, and I think it's important to have a policy that's data driven, and we'll see if Dr. Goyle weighs in. I just texted him, but I know Dr. Patterson obviously is a data expert as well.
No, Rob, I appreciate that, and I think you hit the nail on the head too, and kind of the situation as the fellow kind of guiding the team that you end up in, that you may have an attending on service who says, keep the beta blocker. And when you're talking to the PET lab, they're saying, well, we can't do the test because they're still on the beta blocker. That's kind of the position that I've fallen into both at the Clifton campus and the Midtown campus before, where I'm trying to navigate how to best move forward. I think another interesting thing is, Rob, like you said, the AFib patients where you hold the beta blocker for 48 hours. Technically, if you're going to hold it, you probably should hold it for 4 to 5 half-lives, which, like you're saying, is 48, 72 hours. A lot of times we have patients, they took their beta blocker in the morning, they showed up to the ED in the afternoon, maybe they didn't get their beta blocker the night before, they don't get the beta blocker the morning of the test. If they've been on chronic beta blocker therapy, if you hold it for 1 or 2 doses, are you truly holding the beta blocker, or is there still some in the system that could be affecting the test as well, which I think would be another interesting question.
This is Andy Smith. I have a few comments. One is I think Dr. Hurst would have loved this talk. It showed that you have curiosity. It shows that you think through all the different data. It showed that you question tradition and look at why certain things are done and how they might be done better. The other thing I liked was bringing up the issue of questions that come up on rounds. One of my heroes is Lynn Stevenson in the heart failure world. And Lynn, when she goes around making rounds with the team, she jots down the common questions that kind of come up. And then she applied those questions to an NIH trials in the heart failure network that some of the fellows ran, where we looked at different inpatient therapies. So just encouragement to keep jotting down those questions and looking at things. You talked about the different physiology of how the tests are done. I think another thing that we often need to consider, and one of the fun things about cardiology, is you have to put all the pieces together. So you also have to think about the physiology of the patient that you're seeing. One group of patients we see are patients with severe cirrhosis who have systemic vascular resistance of 500 or so. And what's going to be the impact of giving something that's a vasodilator to those types of patients who already have high coronary flow and may be very vasodilated? Yesterday, I was dealing with an issue of a patient who got hypotensive with dobutamine, a dobutamine stress test.
Oh, wow.
They're all worried about the results, but they gave up the patient a drug that has vasodilatory properties, and the blood pressure dropped in a cirrhotic patient, and the EF went from 60 to 80. That doesn't necessarily mean there was myocardial ischemia. one comment about viability. Our surgeons often point out that that if you have a big blood vessel going to an area of a myocardium, it's probably a viable area. That is, in infarcted areas, you don't see large vessels going there, particularly if you're dealing more with the chronic situation. So use the anatomy to help guide what you may see on a scan. Use some of the wall motion to help try to put it all together. And then just a final comment about the TTR and the PYP scans is that when I started hearing about pyrophosphate scans for TTR amyloid, I said, I used to order pyrophosphate scans. And that was back in the late 80s. And we ordered those tests to determine if the patient had had a recent myocardial infarction. So if you have a patient who comes in with an MI, and then you look at their echo and you say, oh, maybe they have amyloid, and you get a study and it's positive, it may be positive because of a myocardial infarction and not because of amyloid. So anyway, I thought just a fabulous talk. It reminds me of a joke I like about knowledge and wisdom. And I think, you certainly are applying wisdom to how we look at these different tests, but that the knowledge is knowing that that a tomato is actually a fruit, not a vegetable. And wisdom is knowing not to put it in a fruit salad.
Thank you so much, Dr. Smith. That's really great. And I think you really highlight fantastic points from a couple of those the different topics that also, these are not one size fit all questions that we're dealing with, and individualizing it to the patient's pathology is very important. And that's something that even I when putting this talk together, didn't really think about all that much. So I appreciate you bringing that up and highlighting that.
Well, Terry, thanks again for a wonderful talk, and we'll see everybody next Friday if there are no more questions.
Thank you all.
The preceding program is copyrighted by Emory University.